اوكي، عم تسمعوني يا شباب؟ عم تسمعوني؟ هلو هلو.
العادي ما بحي
بين السكرين عندكم؟
دكتور،
سكرين واضح؟
السكرين واضح. ايوه
يلا ببلش.
بلش نعم.
اليوم رح نحكي عن السباين، ويلي رح بحكي عنه هو الاسينشلز يلي لازم انتم تعرفوا فيها بوقت الفحص. ما لازم تعرفوا اكثر من يلي رح بعطيكم اياها. وبعدين ما في نسمع انه ما عطونا سباين بالتريننج، من هيك ليه ما فينا نجاوب. انا بطلب منكم تاخذوا هاللكشه من دكتور خالد وبتحفظوها عن الغايب. Please. The vertebral column has four major curves. The cervical, which is lordotic. The thoracic spine is kyphotic. The lumbar is lordotic. The sacrococcygeal or pelvic column is kyphotic. بدكم تحفظوها هيدي. This shows you the spine. Show the cervical spine. You see that there is cervical lordosis. The thoracic, you see thoracic kyphosis and lumbar lordosis. Finally, the sacral and sacrococcygeal is kyphotic. You have to know also that the angle that we measure, which I will be talking about, the amount of lumbar lordosis is nearly twice the amount of the angle that is for thoracic kyphosis. Okay, yani as a lumbar lordosis is, let's say, 50, thoracic kyphosis should be around 25 degrees. So 50, maybe 25. So keep this in mind. If you look at this slide, you see the diagram on the left-hand side is a patient with a normal sagittal balance. Sagittal balance means that if you draw a plumb line from the occiput on an X-ray, it should be not more than 5 degrees anterior to the vertebral body of S1. In the photograph of the man in the middle, he is in positive sagittal balance, meaning that everything is bent forward and he is an out-balanced individual. Yeah, and he is not balanced. He needs to extend to try and obtain a normal sagittal balance. On the right hand, this thin woman, you see she is in negative sagittal balance. She is tilted behind. So if you draw a plumb line, it will fall behind the vertebral body of S1. What do we mean by gibbous? A gibbous is a prominent thoracic bony ridge. It's caused by a severe kyphotic angle. We used to see a lot of patients having gibbous when we had a high incidence of tuberculosis. This occurs often with destruction of the vertebral bodies anteriorly. So there's no support anteriorly. So the whole spine bends in an angulation. So it most often occurs as a result of an angular deformity caused by the collapsed vertebra, which can be secondary to a tumor, secondary to tuberculosis, or any form of infection, whether fungus or bacterial. This shows you the appearance of a gibbous. If you let the patient stand in front of you and you look from behind, you can see that in the photograph on the left-hand side, there is a slight deviation to the left side. In the middle photograph, you see a hump, a protrusion. It is a thoracic hump. This occurs in scoliosis. And what we mean by scoliosis is a tridimensional deformity where you have a sagittal abnormality, you have a coronal abnormality, and you have a rotational abnormality. We will talk about this further later on. On the right-hand side in the woman, you see that there is a shift to one side. This is what we call a list, a deviation to one side. And this quite often occurs in spasms, muscle spasm. It can occur secondary to a sprain. It can occur secondary to scoliosis. It can occur secondary to infections in the spine. So you have to be able to look at the patient from behind, look at the hips. In the diagram on the extreme left, you see that the left hip is more prominent than the right hip. In the diagram on the right-hand side, you see there is prominence of the right hip, but the left shoulder is higher. So when you receive a patient, first of all, you have to keep in mind that you have to undress that patient. Tell the family that to wear, let's say, a bathing suit, a swimming suit, or whatsoever that will let us expose the whole spine from behind. Look at this slide. You see that the patient is listed or tilted to one side. If you draw a pendulum from the occipital, the central occipital area, or from the inion of the occiput down, you see that the pendulum is not at the slit of the buttocks. It's shifted to one side. On the other hand, if you draw a line in the sagittal view, sagittal, the right-hand side, and you find that the line passes through the sacrum. This patient is balanced. In addition, you should look at the extremities. You should make sure that the lower extremity is not deviate, and one is longer than the other, meaning that one is shorter. You have to have blocks, wooden blocks, to make sure. And you can make sure by putting one of the blocks under the short extremity, and you can see whether the list corrects. This will help you in the diagnosis. In addition, when I say you should undress the patient, this is very important. Why? Because by looking at the skin, looking at lesions on the skin, it will help you in making a diagnosis. On the left-hand side, when you're looking at my slide, you see that there is lesions along the whole intercostal area. And this patient had herpes zoster. On the right-hand side, you see that there are seborrheic keratosis, and we know that there are certain tumors that can be associated with it. So if you look, it will help you in the diagnosis. Another important finding is café au lait spots, and this occurs in two conditions, in Albright's disease and neurofibromatosis. These are brown spots on the body. The difference between one is serrated and the other is smooth. It will help you in the diagnosis. If you look at this, you say this patient has neurofibromatosis. You search for neurofibromas underneath the skin and you confirm the diagnosis. Or if, on the other hand, the patient could have Albright's disease. So pay attention to this. Look for areas of hair loss. Look at the skin. Look at the nail changes. As you see in psoriasis, you see there's ridging of the nails. Search for erythema and cyanosis. All these should be noted, as they may delineate the sympathetic nervous system as the source of pain. Look for tufts of hair, which would tell you, could this patient have a myelomeningocele or a defect or a huge spinal bifida occulta, which is a non-union of the lamina of the spine. Could this patient have a meningocele? You have to pay attention to this. You should examine your patient carefully. In addition, you should never forget the gait of the patient. You should be able to tell the difference between a stance phase and a swing phase. You should know that the stance phase is longer than the swing phase. The stance phase is 60%, while the swing phase is 40%. Pay attention if the patient has any Trendelenburg gait, or whether the patient has a tandem gait. A tandem gait, it tells you whether the patient can walk in a straight line fashion or not. Otherwise, this patient could have a cerebellar problem or any upper neuron lesion. You should know the components of gait. You should know the step length, which is the distance between one heel from behind to the other heel. This is the step length. And you should know the difference from a stride length. A stride length is the distance between one heel and the same lower extremity, other heel, when it hits the ground. You can see this in the diagram. Okay, keep this in mind, please. So, the step length is the distance between the point of initial contact of the one foot and the point of initial contact of the other foot, from heel to heel. In normal gait, right and left step lengths are similar. The stride length is the distance between successive points of initial contact of the same foot, and right and left stride lengths are normally equal. You have to pass through two phases till you reach the stride lengths. This shows you the heel strike, the foot flat, the mid stance, and the push off. طلعوا على هالdiagrams. Look them up. It's not difficult to remember them. This is the swing phase. You have acceleration, mid-swing, and deceleration, which is guided by eccentric elongation of the tibialis anterior, so as to have a smooth heel strike to arrive at the foot flat. So you have the initial contact, the heel with the ground. You have the loading on the second diagram, part of the diagram. Then you have a mid stance where the whole opposite extremity is off the ground. You have a terminal stance, and you have a toe off and pre-swing. طلعوا مش الدotted area. طلعوا the normal foot, مش dotted, مش اللي فيها نقط. Okay, it will tell you heel strike, heel flat, foot flat, toe off of the opposite extremity, heel strike of the opposite extremity. Then you have toe off, and then you go into the swing phase again. لازم تعرفوا انه لما الواحد عم بيمشي بيطلع وبينزل مثل كان طالع على شي سيسور او شي طالع نازل. If you pay attention, you see that the iliac crest rises 1 inch and declines by 1 inch during gait. ولح فرجيكم on the left hand side يلي ما فهم الفرق ما بين stride length the regular length. فرجة detail. You see it on the left, the one which is fully black. You see the heel to the heel from one extremity to the other. It tells you the length of your gait. The stride length is of the same foot, but you have to pass through the opposite foot, and then when the normal foot lands, you measure from heel to heel. So this would tell you the difference between stride length and step length. So keep this in mind. Look at the definition here. Read about the step length, and it will tell you the exact difference between step length and stride length. You will have this from Dr. Khali, please. لما بتكونوا عم تمشوا بتلاقي انه في عندكم fulcrum, which is the hip joint on the left, and you find that on the right hand side you see that there is a shift. It tilts on a fulcrum. It rotates on a fulcrum during the swing phase. يعني ما بتقطعوا دغري وبدل الهيب parallel الهيب. لا، واحد بتبرم والتاني controls. It is the center of action. So in the swing phase, the pelvis rotates 40 degrees forward. The opposite hip joint acts for this. طلعوا بعدين البيت واقف. طبعا اللي بتكون رجال مرة ما بتفرق، بس بتلبس اشياء عليك تفحص ما تفنش شيء، بدك تمشي على الظهر. يعني أنا عملت article على patients in one of the Arab countries, and I found that on a study of around 100 patients, there were around 20 missed diagnoses, which was the result of not undressing the and examining the patient properly. You have to be able to examine the patient from all sides if there is any limitation of motion. You have to rotate the patient, see if there's pain, is there any limitation, is it solid, rigid? You have to record this. You have to examine the patient in extension, inflection, you want to know and record it. You all. This shows you it further. And in this diagram, they show further examinations. راح بقول لكم شو اللي عنا لأن repetition would let you learn. If you look, one of the diagnoses, you have a foot on the thigh, and this is called the flexion, abduction, external rotation position, which is the Faber position. This, when we stress the knee with respect to the sacroiliac joint on the opposite side, and there is pain, it will tell you either a hip problem or a sacroiliac problem, as what would occur in ankylosing spondylitis. Of course, keep in mind that straight leg raising should be maximally positive at 60 degrees. In addition, you should examine muscles. For instance, in the slide in A, you see that the patient is being examined for abduction of the shoulder, which is caused or performed by the deltoid muscle, which is supplied. In B, you see you're examining for the biceps muscle, spine, and this is how you should examine them. So in the exam, when we ask you to examine a patient, you should stress that he should be undressed. Even though we might not ask you to undress him completely, because you have to know that there are many candidates who have to pass by the same patient. And if he spends the time undressing and dressing, he will open the door and leave. So you should mention it, that we should undress the patient completely to see the muscles, to see the skin, to see the position, to see the posture, to see everything in the patient. Now, for wrist extension, you can put your hand on the wrist and prevent it from coming in an extended position, and this occurs secondary to cervical 6 function. If it's damaged, they won't be able to extend the wrist. Wrist flexion is caused by C7, and finger action is caused by C7. امسكوا هالدي طلع عليا. Look, wrist extension, C6. The tricep, we all know about the tricep. Flexion is C7, C8. Finger extension is C7. Keep this repeatedly, you won't forget it. Hip flexion is iliopsoas, which is 2 and 3, lumbar 2 and 3. Is extension of the thigh, and it's 3 and 4, lumbar 3 and 4. Hip abduction, likewise, you have to look at the gluteus medius and examine the adductors, examine the tibialis anterior, Examine the extensor hallucis longus, which is supplied by L5. Examine for plantar flexion, which is supplied by S1. Keep this in mind. You have to grade the muscles. You should learn how to grade. If you have absent function, it's total paralysis. So we give it grade 0, a trace, palpable or visible contraction. We give it grade 1. 4, active movement through the range of motion and gravity is eliminated. We give it grade 2. Fair is active movement through the range of motion against the gravity. So we give it 3. And good is active movement through the range of motion against resistance 4. And normal is 5. You have to learn how to grade these. In addition, you have to know what nerve supplies this and what doesn't. You have to memorize, keep this in mind. I won't go through this list, okay? And you should know what types of reflexes. You should know that C6 is associated with a brachioradialis reflex, C5 biceps reflex, C7 is triceps reflex, and you have to know that C8 is supplied by the hand intrinsics, supplied the hand intrinsics and finger flexes. You have to know these. And for T2 to T12, you have to know whether there's something going on abnormally. You have the Beaver's test. You let the patient put his hands behind the head and ask him to try and flex. If you find that the imbalance goes to one side or the other, it tells you that there is something going on. One of the nerves is damaged. You have to know about the knee jerk. You have to know about the review this. You have to know which one supplies which. The peroneus longus and brevis, S1. Don't forget these. In addition, is paralyzed, they will have a dropped wrist. You should know about the nerve supply of each of the fingers, the median 3.5 fingers, lateral fingers, ulnar, the 1.5 fingers. You have to know if the adductor brevis of the thumb, which is supplied by the ulnar nerve, is gone, then you'll get, and you ask the patient to pose the fingers, he would be unable to flex the metacarpophalangeal joint because the adductor pollicis is paralyzed, and they would have Frohman sign. The aim of sensory testing is to identify whether there is a dermatomal pattern of sensory dysfunction, which would suggest spinal root pathology, peripheral nerve disorders, or possibly a distribution deficit, which would suggest a neuropathy. Be able to tell this. The localizing dermatomes, we know that the thumb is supplied by C6, the middle finger C7, fifth finger C8. If you look at the nipple, it's equivalent to T4. The umbilicus is T is important to let you know whether the patient is out of spinal shock. You should know what the bulbocavernous reflex is. You should know what the cremasteric reflex is. You should know about the abdominal reflexes. All these are important. So you have to study this. It doesn't take much. You have 1-2 hours and you'll get to master them. It's no problem. You should know, if you're examining the foot, where could you find the dorsalis pedal artery? It lies just medial to the extensor hallucis longus. You should know where you should palpate. You should know how a reflex is formed, a simple monosynaptic reflex. If you strike a muscle, a message is sent to the dorsal aspect. It passes and then comes out of the ventral aspect to the motor function to the tendon. So if you strike the tendon or the muscle, a reflex is sent proximally, then through the cord and out through a motor neuron to give you the click or give you a response or to give you, demonstrate a monosynaptic reflex. Reflex grading is also important. If you have absence of a reflex, this would tell you a lot. If it's diminished, likewise. If you have a normal reflex, it will rule out any circumstance that you have in the region. On the other hand, if you have an upper motor neuron lesion, you have hyperactive reflexes, and even you have clonus. Clonus is multiple flexions as you create a motion on the joint, and it starts giving snapping shocks. Distracting a patient may help elicit reflexes through techniques such as the Gendrasic maneuver, having patients pull their hands apart while the stimulus is being applied. And this is the Gendrasic maneuver. يعني بتلهي المريض بإيديه وبتقول له يشد ما بيلونج بعدين you try and elicit the reflexes. This is the Gendrasic maneuver. I repeat, Gendrasic maneuver. What about the Hoffman's reflex? It is triggered by taking the middle finger and flicking the distal phalanx from the palm and observing a pincer movement between the thumb and index finger. This is as is shown in the photograph above. And in other words, you flick at the middle finger. As a result, if you have a cervical myelopathy, what will happen is that this will create an opposition between it, the thumb, and the index or middle finger. Now we have the trauma sign, which is the exact opposite. But then by flicking it up in extension, you flicker the distal phalanx inflection, and it gives you the same response. But one is done in extension and the other is done in flexion. These are reflexes that appear in cervical myelopathy. What I mean by cervical myelopathy is multiple discs or osteophytes with narrowing of the spine in the cervical region. This shows it further, showing you how you can do the trauma sign. The trauma sign is the distal phalanx is attempting to do flexion while your finger is attempting to do an opposite reaction, And if you look at the thumb and the index finger, they will oppose. This is cervical myelopathy. You have the Hoffman and you have the trauma sign. So please don't forget this. These two reflexes may not necessarily be signs of pathology, rather, they may be indications of brisk muscle stretch reflexes. Asymmetry may be significant and may herald the presence of central nervous dysfunction or a significant cervical cord compression, especially in the elderly patients in cervical myelopathy. Another examination is the finger escape sign. And this is بتطلع بالإيد على جهة اليمين يصير تقشع الإصبع بتميل لفرجها. This occurs in cervical myelopathy secondary to weak adductors of the small finger. Enough for this. Let us go to anatomical locations. These locations are important for you if you're going to be a spine surgeon. You should know the hyoid bone. Where is it? Is it at the level of C6? No, it's at C3. So if you're doing an exposure, you want that level, it should be around the hyoid bone, which is at C3. The thyroid cartilage is at C4, 5. The carotid tubercle is at C5, C6, and the carotid body. You have to know these. This is showing you the carotid ring and the carotid tubercle, which is at the level. You palpate it, you can feel it. Try and do it on yourself. Okay? Now, you should know that the mastoid process, which is behind the ear, is at the level of C2. You should know what the superior nuchal line is. This is the upper limit where you can put the plate when you're operating on the occiput. And if you should stick to the medial position, the mesial position. Why? Because the thickness of the skull is most at that level. Another important point in the two cortices of a child in the skull and that of an adult. I want you to answer as such. The outer cortex is matured earlier than the inner cortex. And it is for this reason, when we're applying a halo tongue, we need multiple screws in children because one of the cortices is immature. Again, I'm repeatedly showing you this because this exam will help you in making an accurate diagnosis. Okay? And of course, don't forget about the nerve supply. Don't forget about the sensory supply. C5 supplies the outer end of the arm, C6 the outer end of the forearm, and C7 the middle finger, C8 is the medial aspect of the small finger and ring finger, and then up T1 and T2. Don't forget this. Don't forget about the reflexes. Don't forget about the muscle function, the bicep, supplied by C5, C6. Deltoid, supplied by C5. Don't forget these. Okay, so this would tell you. Also, you should know that the triceps is supplied by C7, and you have to know this. And I'm repeatedly doing this in Hoppenfield's textbook. So this is where I took this from. Okay, don't forget these, please. Now, what is the Sperling sign? This in a radicular nature. This is suggestive of cervical radiculopathy. I'll show you it now. This is the way we do it. We ask the patient to put it to one side, we apply pressure from above, you compress the nerve root, which has a disc, and the patient would have pain in that extremity. This would tell you about the radiculopathy. I'm going to show it to you on a patient. Look at the A. You see how the patient is undergoing pressure and the patient has pain. You should know what the Valsalva maneuver is. Over the lowered, which is C, and in the on stretching the neck, the patient might have pain secondary to further pressure. You have to know what the Nafziger test is. The Nafziger test is when the patient, you bring your hand, you apply pressure on the jugular veins. You know, the jugular veins, you know, there's a backflow according to the veins around the spine due to lack of valves, and this will give you a back pressure into the spine and increase pressure of any disc or object on the spinal nerve or cord, and the patient will have pain. What is Baduki's sign? Baduki's sign is a shoulder abduction test. With the patient in the sitting position, the examiner instructs the patient to place his hand over his head, thus keeping his arm in abduction. This maneuver stretch on the lower trunk of the brachial plexus and relaxes tension on the tethered nerve roots at the foraminal level. Amelioration of the pain usually represents an extradural compression of a root around C6T1. هيدي ما بيصير إلا ما تكونوا شايفينها. When you have a clinic, you see a patient coming to you having a cervical spine problem, and the patient comes in, got unlike this nice looking woman above her head. You ask her why. I feel much better, doc. Well, this is why you are relaxing the pressure on the nerve, and that's why they will have a relief of pain. There are patients who cannot undo this maneuver until they're being operated to remove the pressure from the nerve root. And this is known as Bakody's sign. Bakody's, Bakodys. In addition, you can have the distraction test. You pull the head, decrease pressure on the nerve, it will will increase the canal, the nerve canal root, and as a result, they will have relief. On the other hand, the opposite side will decrease it and they will have more pain. You should know about Adson's test. Adson's test would tell you about the thoracic outlet syndrome, whether the subclavian artery is under pressure. You feel the radial pulse and you ask the patient to rotate his head towards you, towards the extremity. And if the patient, you have an absent pulse, then this will tell you that there is pressure at the thoracic outlet, and the patient would have a thoracic outlet syndrome. The LESEC sign. Flexing the leg at the hip. Flex the leg at the hip. It reproduces the patient's radicular pain in the leg and not in the back. This is a positive LESEC sign, but be aware that at times the hip can give you this pain. And what should you do to tell the difference? Is that if you have a positive LESEC, while you have extension of the knee and flexion of the hip, you leave everything in position and gradually flex the knee. If the pain in the hip remains, then it tells you that the pain is most likely from the hip. If it disappears, then it will tell you that the hip is not the problem. This is a LESEC test. And let me tell you, I put this diagram up for you so that you look at the right-hand side of this slide up. You see a patient sitting, and the LESEC is done with the patient sitting. This would tell you the difference if he doesn't have pain, that he's a malingerer, كذاب, nave. If he says, ouch, I'm having pain. The Hoover test. I do all these tests on my patient. The Hoover's test is, you want to also tell whether the patient is really trying hard to do these tests, to rule out any other pathology and not to be a malingerer. تحطوا ايديكم تحت الكعب تبع كل اجر. هو المريض نايم على ستريتشر، تطلب من المريض يرفع اجر واحدة، بتلاقي انه لما بده يرفعها اذا مزبوط عم يجرب يرفعه ما قادر يرفعها، بيكون عم يكبس من تاني اجر بكعب اجره على الايد الثانيه. يعني you put both hands under the heel. You ask the patient to raise one leg up. When he raises it, طلع انت جربها على حالك. بتحط خلي مرتك تحط ايديها اثنين تحت كعب اجرك. لما بدك ترفع اجر اول شيء بتعمل تكبس الاجر الثانيه على الايد. اذا ما عملوا هيك تقدر تعرف مزبوط عم يجرب يجلط عليك. هيدي بسموها الهوفر تيست. عندك الميلجرام تيست، تطلب منهم يرفعوا 2، بس إذا موجوع ما بيقعد بيقدر، بيقول لك دخيلك بدي وقت تاني إجر. So know the difference between milligrams over Navziget test, Bakudi's test. You should know all these tests. Fazoon, Sperling test. You have to know what the Hoffman test. You have to know what the finger escape sign is. Test. Really, you should try and memorize. This is the milligrams test. تطلب من المريض يرفع الإجرتين. بعد 30 ثانية بتلاقي إنه ما بيقعد بيقدر على الإجر اللي فيها بطال. Sign, the knee is flexed. This is positive if the patient's pain resolves with flexion of the knee. حكيتكم عنها. If the pain persists, this suggests a hip pathology. What about the cramp test? The cramp test is similar to the Lessig sign. The patient is supine. The leg is flexed at the hip and then extended at the knee. It is positive if the patient exists. يعني بدل ما ترفعوا الإجر وتوطوا الركبة، بالعكس هيدا ترفع الإجر نصوي بعدين ترفع من تحت عند الركبة. إذا المريض بيصير عنده وجع لازم تعرفوا هالشيء شو عنده. Okay? So please pay attention to these. These are findings that you should know very well. What is, you know, there are some words which are difficult to memorize, to really, I understand you. نحبل لك إياها. الفرتجن sign is a contralateral شو صار هون؟ يا عم يجيني 2 slides. لا رجعت طلعت يحرق. الأسود طالع على السكرين. راح. Fragistogens. I have to admit, I find it difficult to memorize. Fragistogen sign. This is a contralateral straight leg raise, flexing the leg at the hip with an extended knee of the asymptomatic leg reproduces the pain in the contralateral painful leg. هيدي مثل contralateral straight leg raising, but it has a name. Also, you have to do the femoral stretch sign, which tells you about the femoral nerve. The patient is placed prone and the leg is straightened and extended at the bases. Tension on the femoral nerve, lumbar 2, lumbar 4, and may suggest in upper radiculopathy, like 2, 3, 3, 4 disc. Okay, this is the Fragistogen sign or contralateral straight leg raising. And this, when you have it, if you have contralateral pain on straight leg, And as you're raising that leg up, you're creating tension on the opposite side to be brought towards the disc and pressure, and they will have pain. So please look at this. The Babinski sign. This is an extensor plantar reflex. This is elicited by applying a gentle stimulus to the lateral aspect of the sole, يعني من الإجر من برا, starting over the heel and extending toward the base of the little finger. A positive Babinski sign refers initial dorsiflexion of the great toe upward and spreading of other toes. It is indicative of cortico-spinal tract dysfunction. طلعوا بالصورة تحت ماسك دبوس عم بيحطها من الكعب للإصبع الصغير. تشعل toe. This is positive. بعدين تشعل بقية التوز بيروحوا laterally. They overlap each other. Hey, this is a picture showing you one. Okay? There is another way you can elicit the Babinski sign. It's called the Oppenheim reflex test, using either the opposite end of a reflex hammer, opposite end, it's smooth, or a thumbnail. الأصبع الضفر تبع أصبع كبير بتمشيه على الشين تبع التبية. بتلاقي you'll have a Babinski sign if the patient has it. The examiner uses his or her other hand to scratch along the crest of the patient's tibia in a downward motion. طلع بالصورة. It's self-explanatory. إصبع الكبير الضفر بتمشيه على الكريست بتلاقي بيكون عندك البابنسكي. عندك also the crossed adductor sign. This stimulates the patellar reflex and causes the contralateral thigh adductors to contract. يعني عم تعمل مثل كان عم تعمل ريفلكس للباتيلا وبتطلع على Shattuck sign is present when stroking of the lateral malleolus causes extension of the great toe, indicating damage of the corticospinal tract. So there are three ways: the Shattuck sign, the Oppenheim test, and the Babinski. Know the three tests. One, على lateral malleolus, you strike it, you will have the typical Babinski sign. The other one is called the Oppenheim test, and the third one is the Babinski. What about the Lee Hermit sign? You either flex the neck or you extend the neck. It's due to passive or active neck flexion, even with extension, and you will have pain and electric sensation shooting down the back into the legs. And this is, if positive, a sign of myelopathy and multiple sclerosis. The cutaneous abdominal reflexes, what are they? You have the scratching from the abdominal margins towards the umbilicus and observing a quivering motion of the abdominal muscles. The deep abdominal reflex is elicited by tapping over the anterior rectus abdominis muscle sheath and observing Beaver's sign. This is a very important sign. Patients perform a quarter sit-up. The neck. The examiner should be watching the navel, the umbilicus. The Beaver's sign is considered positive if the navel controlled by the spinal cord below T9 is weaker than the upper abdominal musculature. راح فرجيكم إياها. This is the Beaver's sign. بتحط الإيدين ورا ده. We ask the patient to bend slightly forward. تقشع إنه either to one side or in an irregular area. And this would tell you that there is and one should be careful. This shows you it further, and it goes up. If it doesn't go up, it's normal. This is negative on the left side. But if it goes up and goes to one side, in this position, the umbilical movement indicates a weak segment portion of the rectus abdominis below T9 and paraspinal muscles. And this is a positive Beaver's sign. The cremasteric reflex. In males, this is elicited by stroking the thigh, genitofemoral nerve, and observing the ascent of the ipsilateral testicle. This was the first thing we learned in medical school. The anal wink reflex is contraction. Follows application of a sharp stimulus. This test is used to determine the end of spinal shock in the context of spinal cord injury. Cremasteric reflex by striking the thigh, and you observe the testicle moving up. This is the anal wink reflex. If you have it, it tells you that the patient is out of spinal shock. The bulbocavernous reflex. This is the basis of trauma of the spine. The anal sphincter is contracted by compressing the glans penis. This I will show you it in a photograph. This test is used in the setting of spinal cord injury to identify the end of spinal shock. This is the penis, the glans penis, and he should really have his finger in the anus. If he presses and there's a contraction of the anus, it tells you that this patient is out of spinal shock. Now we come to spinal syndrome. The spinal syndromes. We have the central cord syndrome. The central cord syndrome occurs in the cervical level and usually results from a hyperextension injury, what will happen? You have a thickened ligamentum flavum, and you have the cord. They come across each other and they compress the cord. Now, this central cord syndrome has something which would surprise you. They will have weakness of the upper extremity more than the lower extremity. And why does this occur? You should know that the fibers of the upper extremity are more external, more superficial. So when this pressure occurs, it occurs more on this group of fibers rather than occur more on the deeper fibers. So as a result, they will have weakness of the upper extremities more than the lower extremities. This typically occurs in an elderly stenotic, spondylotic cervical canal without associated fractures. It's already stenotic. We have the flavum, the ligament flavum, the yellow ligament. It's thickened also. So what happens? This cord will become compressed between the narrow canal caused by osteophytes, by narrowing of the canal, and the yellow ligament. They impinge on the cord. This occurs when they fall. They can have a hyperextension injury, or rather any injury which would narrow. So you have a spinal cord injury pattern in the central cord syndrome. Brown-Séquard syndrome. Brown-Séquard syndrome results from a hemisection injury of the spinal cord. It is manifested as ipsilateral loss or diminished appreciation or function of voluntary motor control, conscious proprioception, and discriminative touch below the level of the lesion. What happened? لنقول واحد اتقوس and it comes through one side of the cord. What will happen? You'll see that we know that the fibers of pain and temperature descend and then they cross to the opposite side. So they will have loss of pain and temperature on the opposite side. And they will have loss of touch, motor function on the same side. So it's a contralateral loss or diminished appreciation or function of the sensation of pain and temperature may occur below the level of the lesion. This is a hemisection of the cord, a Brown-Séquard syndrome. And if they ask you which partial cord syndrome has the best prognosis, you should answer that the Brown-Séquard syndrome has the best prognosis. The anterior cord syndrome occurs from damage to the ventral portion of the spinal cord with interruption of the ascending spinothalamic tracts and descending motor tracts. There is loss of pain and temperature sensation again, along with a loss of motor control. This shows you spinal cord injury pattern in anterior cord syndrome. Now, I will take a 2-minute break بس راح تريح صوتي يا جماعة. Am I clear so far? يا شباب, am I clear? واضح؟ ما حدا عم بيجاوب، ليه؟ يا جماعة.
نعم كليل.
اوكي انا دي
ماشي ماشي. لا لا، هو عندهم ما يسمى.
بس صدقوني هاللكشر مهمة كتير إذا بتفكروا فيها. It tells you how to examine a patient in a correct way. It tells you what reflexes you should know. It tells you about the motor power of all parts of the body. It tells you about certain anatomical aspects. It tells you which of the spinal cord partial injury syndromes has the best prognosis. So this is very important before I go into the essential anatomy of the spine. So I'm going to start, then I want to finish early. Good. Osseous components of the spinal column. We know that there are 7 cervical vertebrae, as I mentioned, 12 thoracic vertebrae, 5 lumbar, 5 sacral, and 4 coccygeal vertebrae. We have to know about the spinal ligaments of the spine. There are 3 sets of ligaments that we should know in the spine. We have the anterior longitudinal ligament. This is the largest. It is the thickest ligament. We have the posterior longitudinal ligament. It is thicker over the central body posteriorly, but at the periphery it is thin. من هيك ليه when you have a disc rupture, it comes out posterolaterally. You should know about the facet joint capsule and the ligaments about it. This is a diagram that tells you where the anterior longitudinal ligament lying on the anterior aspect of the vertebral body. And you have the vertebral body. As you go down, it becomes wider. It becomes wider. Why? Because it has to support more weight. And if you go into the vertebral body, you see that it consists of mainly cancellous bone with a thin cortex. So don't forget this. From behind, you have to know about the ligamentum flavum. You have to know about the supraspinous ligament, which lies over the posterior aspect of the spinous processes. You have to know about the interspinous ligament between each of the spines. Know about the facet capsule. Never forget about the posterior longitudinal ligament, which is thicker in the center and narrower at the periphery. In between the vertebral bodies, you have a soft tissue component, which consists of the annulus fibrosus and the nucleus pulposus. The annulus fibrosus is quite elastic, and it consists of type 1 collagen. And in the center, you have the nucleus pulposus, consisting mainly of type 2 collagen. It has proteoglycans, and it consists of 70 to 80% of water. This soft tissue component is the amortisseur, or the spring or the shock observer of the spine. In the evening, at night, it is very low. Why? Because with compression, they lose the water. During the morning, when the patient wakes up, it is thick and wide. It has the maximum amount of water. So don't forget this shock absorber. Don't forget that this shock absorber does not have a blood supply. It receives its nutrition by means of imbibition. Imbibition by seepage of fluid through the annulus, through the cartilage and plate to give nutrients to the various portion of the disc. The anterior longitudinal ligament is generally thicker than the posterior longitudinal ligament. The facet joint capsule is thought to be innervated. This is important. We like to ask this question in multiple choice questions. The facet joint is thought to be innervated by the nerve to the facet capsule, the anterior longitudinal ligament, the posterior longitudinal ligament, and disc by the sinovertebral nerve. Don't forget this, sinovertebral nerve. All of these are thought to contribute to discogenic degenerative pain syndromes. A particular arrangement of 3 ligaments forms the transverse, the apical, the alar ligament complex of C1, C2 articulation. كلنا atlas or axis, we have a special connection which is done by 3 main ligaments: the transverse, the alar, and the apical ligament. The transverse ligament runs horizontally behind the dens and is the major stabilizer of C1, C2 segment. It is 6.9 millimeters in length. It is crossed anteriorly by the vertically oriented apical ligament. Finally, a paired set of obliquely oriented alar ligaments adds support to the articulation. This is a diagram of these 2 vertebrae. I want to tell you briefly is that the axis is a thief. It stole the body from the atlas, but it has a strict connection to the atlas through this body, which is known as the odontoid process. It has 3 ligaments to connect to the axis. You have a transverse ligament, you have an apical ligament, and you have an alar ligament that connects to the occipital condyles. This motion in this region is mainly rotation. We know that 50% of the rotation of the spine occurs at the level of C1, C2. In addition, you should know that from C2 to C6, all the spinous processes are bifid, meaning عندك قرنين, bifid. Now, about the alignment. the thoracic kyphosis averages 35 degrees, and the range is 20 to 50 degrees. The normal lumbar lordosis averages 60 degrees. As you recall at the beginning of my lecture, we said that it's about twice as much as the thoracic kyphosis. Up to 75% of lumbar lordosis occurs at the level of L4 through S1, and up to 47% may occur at L5, S1. So if you're asked at what level of lordosis in the lumbar spine is most, you tell them at L4 through S1. If you want to know which portion, it's mainly L5, S1. Men with low back pain tend to have decreased lumbar lordosis. Let's go back to the cervical vertebra. The spinous processes are bifid, except C7 and sometimes C6. We mentioned the C1 atlas has no body or spinous process. Instead of having, they have a tubercle and two lateral masses. I will show you that. The C2 vertebra has the odontoid process, the dens, which articulates with the anterior ring of C1. Now, we have over here what? We have here a typical cervical vertebra. If you look over here, the transverse process is this. Through the transverse process, we'll have a foramen, which is called the foramen transversarium. In this passes the vertebral artery. You have an anterior and posterior tubercle for muscle attachment. And over here you have the articular processes. This is the bifid spine, and this is the body and the facet joints. This shows it further. If you look at the atlas, you see, I want you to learn this. This is very important. I call the atlas a rondelle. Why do I call it a rondelle? A rondelle in French means it's a, I forgot what it means in English. So it's a connection between the upper portion and the lower portion. Its facets are facing inward. It joins with the facets of the occiput. بتسكر عليهم على الجانب تبع كل فساد في الvertebral artery. At this level, the vertebral artery angulates and goes to the foramen, the obturator foramen, and goes into the brain, and it becomes known as the basilar artery, meaning on the posterior aspect. I'm showing you, I thought this was, no, the posterior aspect. It goes to the foramen, the occipital foramen, and into the brain as the basilar artery. You have an anterior arch, you have a posterior arch. The anterior and posterior arch, the anterior is smaller than the posterior arch. And you have the lateral mass. When we are applying or inserting the marginal screw, we like to go through the lateral mass, and I'll show you how we do it. The T1 vertebra has a long, prominent spinous process. the vertebral prominence. The angled spinal processes overlap significantly. The costal facets, articulations of the ribs with the vertebral segments, are present on all vertebral bodies and معلقة هيدي شو هيدا؟ خليها هيدي. Okay. So much the better. أحلى. The costal facets, articulations of the ribs with the vertebral segments are present on all vertebral bodies and transverse processes from T1 through T9. خليني أفسركم ليه the thoracic spine is more stable than other areas. Because we have the ribs, we have the intercostal muscles, and we have the connections, both posteriorly and anteriorly to the sternum. So for someone to have an injury and displacement of the thoracic spine, it must be really a high energy injury. And if you see a fracture of the sternum, you have to always think of a fracture of the thoracic spine. What do we mean by vertebral prominence? This occurs at the level of T1. You see the spinous process is very long, and it helps us during surgery. It helps us during surgery, being very long, and we can tell the anatomic location, especially when we're doing the posterior approach. What do we mean by the ribs and the support of the thoracic spine? The rib has three attachments. One to the transverse process. This is the tubercle of the rib and the ligaments attaching to the transverse process. Over here, you have two attachments, one to each side of the vertebral body. So you have a good fix. And for this reason, it's much harder to fracture the thoracic spine. But you have to think of something else. In the cervical spine, in the upper cervical spine, the spinal cord measures 1/3 of the diameter. The odontoid process measures 1/3 of the diameter, and the free space measures 1/3. For this reason, fractures in the upper extremity are often really not associated with nerve injuries or cord injuries as much as those in the lower extremity. This is the rule of threes, the rule of Dennis. 3, the cord, the empty space, and the odontoid process. In the lumbar area, you have more of a wide canal than the thoracic. But the thoracic spine, you see that the cord nearly occupies the full space. This, in my opinion, is why we have so much protection for the cord in this region. The lumbar vertebrae have large bodies with rectangular, non-overlapping spinous processes. These vertebrae have very large pedicles with similar transpedicular screw starting points L1 and L2 typically have smaller pedicles than T11 and T12. Okay, you have to pay attention to this. I'll tell you, when I'm putting pedicle screws in the sacrum, I don't worry, because the pedicle is around 1.9 centimeters in diameter. In the lumbar area, it can be 8 millimeters, 7 millimeters, 6. Then you move up to L1, L2, it goes down to around 4 millimeters, 5 millimeters. And then you go up to T11, T12, it goes up more, and it's thicker, it's larger, there's more diameter. The thinnest diameter is the level of T4. Pay attention, in the thoracic spine. In the cervical spine, you can apply pedicle screws at C2, but the rest of the areas you cannot. It's very risky. You can go through the vertebral arteries. So be careful of this, please. Okay, thank you. Now, you have the spinous process, you have the mammillary processes, you have the accessory processes, transfers, you have the pedicles shown over here, the vertebral body, you have the various facet joints. The facet joints change from one area to another. In the cervical spine, they're nearly more or less horizontal. The thoracic spine, they're vertical. That's why you have rotation and very minimal lateral tilting of the spine. And in the lumbar spine, it's in between, and you have flexion, extension being the most. The sacrum is a single structure formed of the 5 fused embryologic sacral vertebrae. It has 4 sacral foramina through which run S1 through S4 nerve roots. The S5 roots run inferiorly through the sacral hiatus. The broad superior sacral LA is similar to the transverse process of the more superior spine and is a major target for lumbosacral fusion graft material. I'm going to show you. If you look at the sacrum, you have 4 sacral foramina on each side. This is when you're looking at it from the front. If you look at it from behind, you see the 4 sacral foramina plus a sacral hiatus, which is an opening at the bottom, okay? From the front, you see the S5 vertebral body. On the right-hand side, you see that you have a defect. This is a foramen called the sacral hiatus, through which S5 passes. The intervertebral disc complex and vertebral bodies support more than 80% of the axial load transmitted through the spine. The discs are central to the functional spinal unit. What we mean by functional spinal, the vertebra above, the vertebra below, and the disc in between. This is the functional spinal unit, which comprises the vertebra above and below, the disc, and the associated paired facet joints at that level. The disc consists of a fibrous outer annulus fibrosis with obliquely oriented collagen 1, I repeat, collagen 1 molecules, and a softer inner core called the nucleus pulposus, which cushions force with predominantly type 2 collagen molecule. إذا سألتوا هالسؤال لازم تعرفون إنه بالnucleus pulposus it's type 2. Don't forget in the nucleus pulposus you have the proteoglycans. Don't forget that you have the water, which is in children 80%. Later on it declines to 70% water. What about the facet joints? Also called the zygoapophyseal joints. The facet joints are the articulating components of the spinal unit, which we mentioned about it. It's called the functional spinal unit. FSU is the functional spinal unit. The orientation of these joints varies through the spine in accordance with the predominant direction of allowed motion at that level. While there is a smooth transition throughout the spine. The motion allowed in each spine region is roughly as follows. In the cervical, you have coronal and 45 degrees sagittal. In the thoracic spine, you have 20 degrees coronal, 55 degrees sagittal. In the lumbar spine, you have 50 degrees coronal and 90 degrees sagittal. The superior tip of the inferior articular process is a main that you have to study the anterior cervical approach. This approach uses a plane between the strap muscles, the trachea, and the esophagus medially, and the sternocleidomastoid and carotid sheath laterally. After sharp or blunt dissection, first through the pretracheal fascia, the platysma, and then the prevertebral fascia, the midpoint of the anterior spine is identified between the longus colli, the paired longus colli muscles that must be detected medial to lateral. Let me show you this. Over here on the left-hand side, you can make a longitudinal incision or a transverse incision. You divide the platysma. Then you have the sternocleidomastoid from one side, and you have the neurovascular bundle. This is the outer aspect. The medial aspect, you have the thyroid gland, you have the trachea, you have the esophagus. You go in between these, you reach the longus colli muscle, and in the middle, you should approach the disc in the middle, and you can arrive. Look at this diagram. It is very easy to memorize, and you have to pay attention to one nerve, the vagus nerve, which arises from the 10 central nerves. It gives the superior laryngeal nerve and the recurrent laryngeal nerve. The superior laryngeal nerve can be damaged, and as a result, they can have difficulty in swallowing, while the recurrent laryngeal nerve on the left-hand side, in a regular fashion, between the esophagus and the spine posteriorly. And the chances for damaging it is less than on the right-hand side, where it curves around the right right subclavian, I think, subclavian artery, and yes, it's the right subclavian artery, and then goes mesially to lie in between the esophagus and the posterior structures, and namely the longus colli. You have to pay attention that you should not damage these. The recurrent and superior laryngeal nerves are particularly at risk for injury during this approach. Injury may lead to temporary permanent vocal cord paralysis. The recurrent laryngeal nerve is a branch of the vagus from the cranial nerve 10. On the left, it turns beneath the aortic arch, ascends in the tracheoesophageal groove directly. On the right, is variable. It crosses under the subclavian artery and is usually in the surgical field, often 50% of the time, crossing to the tracheoesophageal groove at C5, C6. Injury to the superior laryngeal nerve may damage the mucosal sensation reflex, and it will prevent which prevents aspiration. بيجي الواحد يمكن بيختنق بالاكلات تبعه. Cutaneous landmarks for the anterior approach. You have to use the cricoid membrane at C5, C6, the prominence of the thyroid cartilage overlying C4, 5, the hyoid bone at C3 level, the angle of the mandible is C2. You have to use all these landmarks. The posterior cervical approach is a longitudinal incision made through the skin down to the ligamentum nuchae and supraspinous ligament. Following the bone of the spinous process, one can dissect down to the cervical lamina and out onto the lateral masses as needed. Dissection anterolateral to the posterolateral margin and the lateral masses places the vertebral artery at risk. لازم تنتبهوا على synovial joint of Luschka while you're doing the anterior approach. You should not go beyond it because the vertebral artery is 5 millimeters lateral to the sinoatrial joint. This is the posterior approach. Anterolateral approach of thoracolumbar spine. You have to know you put the patient in this position and you go, if you have a vertebra at level of T4 you want to expose, you should go search for the ribs of T2. You go 2 ribs above and then you make your incision. You separate your ribs and then you go into to arrive at the vertebral body from the front. I'll tell you this, I'll be very honest. In my first few cases, I always used to have a cardiovascular surgeon with me. The rib 2, higher than the vertebral body, to be approached is selected. The skin is incised along with the posterior musculature, being careful to tag the matching fascia, and the dissection is carried down to the rib itself. A subperiosteal dissection is performed around the rib, carefully avoiding the neurovascular bundle on the inferior surface of each rib. The rib is then resected and can be used for bone graft. Incisions through the anterior periosteum and parietal pleura allows access to the thoracic cavity. A right-sided approach is preferred, allowing for more complete retraction of the lung, heart on the left, and avoiding the aortic thoracic duct and the large segmental artery of Dankiewicz. This is present at the level of thoracic 8 on the left side. This is a segmental artery which is important for blood supply of a good portion of the cord. And if this is damaged, the patient will end up paraplegic most of the time, and as a result of infarction. The azygous system is dissected anteriorly with the vena cava by subpleural dissection on the lateral vertebral bones. The segmental arteries must be identified at the waist of the mid-body between the intervertebral discs. These can be ligated after identification. Resection of the rib head allows visualization of the foramina, pedicle, and demarcation of the depths of the posterior vertebral body. More unfairly, the diaphragm can be divided. We divide it 1 to 2 centimeters above the muscular tendinous junction. This must be tagged carefully and repaired. More medial incision risks damage to the phrenic nerve and muscle of the diaphragm could occur. The peritoneum is swept anteriorly, and the psoas is retracted. We know that the genitofemoral nerve is present with the muscles within the iliopsoas and the brachial plexus. One should be aware of doing strong retraction or going through this, because you can end up having paralysis of these fibers. As a result, the patient can present you with a limp and pain in the hip. These structures are at risk, as are the ureter and more distally the iliac vessels. With a direct anterior exposure, I've resected 3 chordomas in my life. I had to go anterior. One of them I had to go both anterior and posterior. Why? Because it was large and more proximal. I had to dissect the median sacral artery and the iliolumbar vein. I had to ligate them. I dissected the tumor free from the front, and I covered it with cellophane. And then after 1 week, I went from behind and removed the rest of the tumor. Only in high-level chordomas would you have to go anterior and posterior. In low levels, you can do the complete resection from behind. The posterior thoracic and lumbar approach we know very well. This is how we approach it. The patient is positioned prone and carefully padded. Avoiding external pressure on the abdominal contents will minimize intraoperative bleeding. The most common palpable landmark is the superior margin of the iliac crest. لازم تعرفوا إنه the upper margin is equivalent to L4-5, and the posterior tubercle from behind is equivalent to what that portion S2. Dissection is carried out down the spinous process and internervous plane to remove the insertions of the paraspinal muscles. The transverse process of the lower lumbar vertebra is at the level of each facet joint. I'm not going to go through this because this is too advanced. Now we go into the diseases. I'll have my second break, rest 1 minute, 2 minutes, and then we'll go into the conditions. This is the interesting part of this lecture. 2 minutes, 3 minutes break يا جماعة.
عبد الرقيب.
مع مين؟
دكتور عبد الرقيب.
يا أهلا يا أهلا. في
أهلا فيك دكتور جون.
نعم.
Do you prefer the right side approach when you want to do transthoracic approach?
Nowadays, we're trying to avoid it. Let me be honest. We're trying to do everything posterior. But if we're forced to, we have no choice.
You have a disc in the thoracic spine. You can approach
that's a very good question. Very good question. It depends on the position of your disc. If it's central,
yes, sir.
You should remove it from the front. If it is peripheral, we have removed a few discs through the costal transverse approach. We remove a rib, we remove the transverse process, and we reach it laterally. The reason why we don't like to use this very often, we had one case that we went posterolaterally, we don't like it. For this reason, the majority of our discs in the thoracic region were going to the front. Am I clear? Hello.
Okay. Yes.
شو
clear.
عندك أنت suggestion? What approach would you use?
I always custom to made and transthoracic through the left side because we fear from Finaka.
You're speaking about which side?
Yes.
Left side. At what level? At what level?
From D6 to D10 like this.
I agree, because if you want to do it from the right side, you have the liver. You have so many structures. You have to do it. Okay? But if you go up at the level of T1, T2, T3, T4, there are some surgeons who prefer going to the right side.
Transthoracic?
In the upper level.
But it's difficult to go through T1, 2, 3, or through because the scapular obstacles to approach through.
I do agree with you, but there are some who do it. But I'll tell you, the far majority we go through the left side. Okay?
Yes, okay.
But I wouldn't say that everybody doesn't do the right side approach. I wouldn't say it.
It is a matter of adaptation or experience.
Exactly. But definitely, I agree with you. From T6 down, you have to go from the left side. But why they like to go through the left side? It's easier to dissect the aorta and put it aside rather than dissect. This is it. We'll be catching نكون ماسكين قلبنا بإيدنا when we're dissecting the vein.
Yes, you're right.
Okay. In the sacrum, when we go from the front, really we get vessels which are facing us that we have to dissect and ligate. You have to think of this. The mid-sacral artery and the sacral vein is very difficult. You have to dissect them, otherwise you'll run into problems.
Yes.
I'll be honest. You want me to be honest. Many of these cases, which I have to go from the front, I usually ask for a vascular surgeon to be a couple assisting me. I'll be very honest. There have been very few that I have done alone, but it was a hell of a lot of panic.
Yes.
Okay?
Yes, okay.
We're going to go into the cervical disc disease. رح برجع بلش يا شباب. رح نشرب نقطة مي وبلش.
Nice.
Now, we all know that one of our biggest problems is spondylosis, which occurs with age. It's a natural process. It's difficult to see someone after the age of 65, 70 without having a problem somewhat in the neck. With time, you have desiccation, you have narrowing, you have bulging, you have kyphosis, you have loss of lordosis. When we have loss of lordosis, it limits us. Mind you, it's easier to go and operate from behind, but we cannot operate if we have loss of lordosis, unless we have to use some sort of fixation. You have to pay attention that with time they form osteophytes at the posterolateral margin of the vertebral body. And this is known as uncinate spurring. You have to know that there's facet arthrosis with osteophytes. You have to know that you can have these patients probably at one time or another had the herniated nucleus pulposus. Now we know that in the cervical disc, cervical spine, taking it naturally throughout the years, the most common site for a disc to occur is C5, C6. The second commonest is C6, C7. And the last is C4, 5. What are the risks? They occur from lifting. Believe me, if somebody tells you about the cervical spine, you say lifting is one of the causes. Why? Because when you're lifting, you're tightening the paraspinal muscles, the sternocleidomastoid, the muscles on each side of the spine. All these promote production of a disc. And cigarettes and driving. Many people like the four-wheel drives, but these are bad because the springs are very bad. Now, before I carry on, I'll tell you, these lectures, I have taken them from review courses. Some are exact copies, others are not. So I'm doing this mainly for the board exam, so as to have equivalent questions. Keep this in mind. So you have to think of discogenic neck pain when you have a disc, and you have to think that, I don't know, in the past there was a lot of talk about the hard disc resulted from an osteophyte or a soft disc, which is mainly of soft tissue. And you have to divide the cervical spine with something that occurs in many of us with aging. And this is known as cervical myelopathy. And you have to know that cervical myelopathy in the past was, they didn't advise us to treat the third or fourth stages. Why? They said that they will not heal, they will not improve, they will not. Nowadays, we operate them to prevent it from increasing. In the past, we did not know this. And we classified it into 4 types, Neuric 1, 2, and 3, and 4, depending on the severity of the condition. Now, you have to be aware of, you have to not always trust your MRI findings. And if this patient has a disc, has a problem, etc. There are many people who have abnormal MRI findings in the cervical spine and yet never had any complaints. We know that under the age of 40, 14% have abnormal MRI findings. After 40, 28%. Not only consider what you see by MRI, you have to consider have observed on examination, on your history. You have to put them all together and then arrive at the diagnosis. مش خبط لازق تيجوا بتقرروا MRI في ديسك بدنا نعمل له عملية. It's not true. So many MRIs have a large disc and the patient never complained of any pain. You have to know the route, the supplies of C5, C6. You have to know that the nerve which is irritated, it's the one below. It's C6. C6, C7, it's C7. You have to know that in the cervical spine, nerve which is irritated is the one below. In the lumbar spine, it is so, but not always, because if you have a transverse disc or one through the foramen, the level will be at the same level. So you have to pay attention to this. The conservative management is non-steroidal anti-inflammatory drugs, but not for long, not for more than 1 week. In the past, we used to keep them long periods. And what did we end up with? Patients having kidney problems and dying from renal insufficiency. Put the patient in a collar. A physiotherapist should give him physiotherapy. Traction is excellent, but not too much. And localized injections. When do we do surgery? Persistent, painful radiculopathy. If it lasts more than 6 weeks, we will consider doing surgery. And of course, progressive significant weakness, myelopathy, MRI for pre-op evaluation is indicated in all cases. We don't do an MRI early in patients that we're treating conservative. In the States, we even don't do X-rays. We wait for 6 weeks to have a plain X-ray. Now, the question is that we do the far majority of our surgery through the anterior approach. And we end up doing fusion. There is some surgeons who use a discoplasty, yani bringing a prosthesis. I don't think the long-term results have been good, and I don't think there has been any significant difference between it and the fusion. Some patients, you can do a keyhole foraminotomy, especially if you have a soft disc. One should avoid laminectomies if you're doing the posterior approach. Why? Because you'll end up having a progressive kyphotic deformity. We prefer to use autografts. To remove too much lamina from behind, we usually do a lateral mass fusions using rods. You have to know the Smith-Robertson approach and know the complications. What are the complications of surgery? Recurrent laryngeal nerve, paralysis, and compression. If you go too far laterally, you can have a vertebral artery injury. And the rationale is that if you have injuries. Pseudoarthrosis is quite common, more common when you go 3 or 4 levels above, more than 2, 3 levels from the front. It's not always painful. And if you have to do too much, it's better to go both anteriorly and posteriorly on these cases. Cervical myelopathy, we know congenital stenosis is one of the major causes. An example would be achondroplasia, spondylosis, anterior bars, kyphosis, ossification of the posterior longitudinal ligament, especially in Asians, is one of the causes of cervical myelopathy. So you have to remember these. What happens? The patient will have a gait deterioration, which is the most significant complication. They have a broad-based shuffling gait. They have upper extremity weakness. They will come to your office saying, I cannot button my shirt anymore. And they will have signs and symptoms of an upper motor neuron lesion. And they will tell you, I've lost control of my bowel and bladder. But this is rare. What is this? This is natural history, telling you of how the patient has kyphosis with time and narrowing of the canal. There are special measurements that we use. We have to know that the width of the canal is 17 millimeters. If it becomes less than 13 millimeters, then we say we have stenosis. You have to know Pavlos-Stokes ratio by dividing the width of the canal by the vertebral body. If it's less than 0.8, then you have to think of stenosis. And whenever you have spondylosis, you have loss of lordosis, and this increases the narrowing of the canal. Yeah, if you do an MRI, you see that there's stenosis and cord flattening. They asked me once, what is the difference between the appearance of a bony narrowing and soft tissue narrowing? When you have stenosis, what happens? The pressure is anterior to posterior. You see that the cord will become wider and narrower in the anterior direction. I'm showing you it in the lower end of this slide. What is the treatment? Non-operative treatment is debated. Surgery should be done if you have gait changes, progressive dysfunction, hand involvement, and of course, the age. The age is important. Anterior, you can do a corpectomy plus a strut. You can do 1, 2, or 3 levels. And of course, do a fusion. I've done many cases, 3 levels, but you have to bear the consequences that the incidence of pseudoarthrosis is higher. The Japanese like laminoplasties. They do multi-level disease. This way, they claim it preserves the lordos. And the advantages is that it avoids kyphosis and maintains motion. When you do laminectomy alone, you are certainly risking kyphosis. When you do a laminectomy, you have to consider either lateral mass plating or insertion of a rod. The results with surgery, you have 80% have some pain relief, and 90% have neuro improvement. It's not as so as we used to think of in the past. So the prognosis depends on the severity of the myeloma. When did the patient come to you? And the degree of cord compression and the age. And you have to think of the complications. Let's speak briefly about the spine. "25 to 80% in rheumatoid arthritis involve the cervical spine. They also have multi-joint arthritis, mutilins. Males, the disease duration is more severe. All have been on steroids. The pathology involves the synovial joints. It involves the posterior aspect of the dens. Why? Because we have synovial tissue over there, and this becomes inflamed and has a pannus. We know that the ligaments, when involved with the rheumatoid arthritis, they become lax, and then as a result, the gap between the odontoid and the anterior arch of the atlas increases, and the space available for the cord between the posterior aspect of the odontoid and the anterior margin of the posterior arch of the atlas depression. Level, and it starts migrating superiorly, and it even may go into the foramen magnum. So you have not only this, you have subaxial instability, you have C1-2 instability plus other joints. And Ranawat made a classification. And I wouldn't hold you responsible for the Ranawat classification unless you're a specialist. We don't ask you so much. So I'll tell you, if you're interested, look at this in this lecture. The diagnosis, early you can do flexion extension views. You need an MRI to see the pannus, the thickening. You need to see more or less the distance between the anterior artery of the atlas and the odontoid. You can do tomography. And of course, we use somatosensory evoked potentials in these cases. You have to know the measurements present. You should know what McGregor's line is, what McRae's line, what Chamberlain's line, what the power line, all these you should know that. And you should know when would you say that a odontoid has gone into the foramen magnum. So these are measurements you have to know. All you should know is that with the ligamentous laxity, you have anterior instability, you have narrowing about the cord, and you can have sudden episodes of death. Okay? You'll have a motion between the facets, and this can further damage the cord. You have to also pay attention if you have a patient who has rheumatoid arthritis and you're operating for any other condition, you have to warn the anesthesiologist that the patient has such a thing, because you can lose the patient if the anesthesiologist is not well acquainted with the patient. Many patients should reach the OR with a collar. And I'll tell you, in several of my cases, we've done in awake intubation. Okay. Don't forget what I told about the space available for the cord. When it becomes less than 14 millimeters, you have to operate. And this applies to Ranawat 3, operate. Look it up. I'm not going to go through this. You have to be aware of basilar invagination. The dens is in the foramen magnum. You have to know about Ranawat line less than 14 millimeters. You have to know more or less about neural compression. You have to realize that if you have subaxial subluxation, this adds to instability. You can do a posterior spine fusion when you have this unstable. We insert a marginal screw and we wire. You have to be careful. Don't forget about the occiput atlas. If it's unstable, you might be doing harm. At times, I use the summit to fuse occiput to axis, and I found that the patients are more comfortable when I do this. Spinal cord injury. 10 to 14,000 traumatic cases in the United States occur annually. It's more common in males aged 19, and we found that it's more common on weekends because they drink alcohol and rye, more common during the July-August months. The etiology is most commonly motor vein accidents, falls, gunshot wounds, sports, diving, gunshot wounds increasing maybe to 50%. In the United States, 90,000 people died from gunshot wounds in 1 year. They are the stable nation. But I'll tell you, this is something which you have to consider. Spinal cord injury syndromes. We spoke about it. No distal function. You have to examine for the bulbocapillus reflex. Make sure it's intact to see whether it's complete. You have to see what level it is. Is it C6, C7? An anterior cord is loss of motor, as I mentioned. The sensation could be intact. It may mimic a complete injury. And this is the worst prognosis. The central cord, we spoke about it. The upper extremity is worse than the lower extremity. It's most common in elderly patients. It has a good prognosis. They can end up having good bladder control, and the hands might not be so clumsy. The brown scar is usually a penetrating trauma. They have ipsilateral paralysis and contralateral pain and temperature gone. It has the best prognosis, but ventral cord has a better prognosis than the anti-record syndrome. So you have to pay attention to complications that occur. You have to be aware of neurogenic shock and distinguish it from hypovolemic shock. What is characteristic of neurogenic, they have hypotension and bradycardia, while hypovolemic, they have hypotension and tachycardia. You have to be careful to be able to tell this. And if they have it, you can give pressors. Be aware, don't give too many fluids because you can push them into edema, pulmonary edema. Beware of the skin for ulcers. Beware of the bladder for infections. You have to look into any of the reflexes to be able to tell various conditions. Yani, if the patient hasn't had a bulbous cavernous reflex yet, you can demonstrate it by pulling on the folic acid. There is questions about the steroids. If the injury is less than 3 hours, I would very gladly give steroids, but you have to realize that the risks of giving such a large dose is high in these patients. And there hasn't been significant changes or improvement. But for medical legal reasons, in certain places of the world, you have to give steroids, while in the United States, they're swaying away from giving steroids. Steroids are contraindicated in gunshot wounds, pregnancy, and in children younger than 13. You should try and initiate them before 8 hours and better before 3 hours. We give 30 milligrams per kilogram weight over the first hour, followed by 5.4 milligrams per kilogram body weight drip for 23 hours. And at times we continue the drip for 48 hours if stopped. Between 3 and 8 hours. Steroids, you should not forget them. Apply skeletal traction. Try and reduce the fracture dislocation when awake and you have an alert patient who cooperates with you. You should routinely, in the cervical spine, fracture dislocations where you have a facet jump and you have disc narrowing, you should investigate and make sure there's no disc. And it's advisable to have an MRI. I've had many people with unilateral facet dislocations and bilateral facet dislocation who were not paraplegic, not quadriplegic, where they were awake. I reduced the dislocation gradually with traction, and every increase in increments, I would do a neurologic exam, and then I would get my reduction. But in these cases, it's not enough to do a reduction. You have to do a fusion because these are ligamentous injuries. Always, before open reduction, we do an MRI. Always for neurosurgical worsening, consider for acute disc space narrowing, consider for neurologic intact no for complete spinal cord injuries, and in incomplete is a question. So MRI always before open the reduction do it. This X-ray on the side is a bilateral facet dislocation, and these, what we do is we do a gradual reduction. We put the patient in a halo or use any form of tongues, and with traction, gradual traction, and neurologic examinations, we reduce them. Now, there are certain centers who will not do this before doing an MRI because of fear of a disc rupture and the patient becoming paraplegic or quadriplegic. Incomplete spinal cord injuries decompress when neuro plateaus increasingly early, decompress for worsening neurologic status, decompress for root return 1 to 2 levels, and complete spinal cord injuries stabilize to facilitate rehabilitation, decompression for root return. You have to pay attention that with cervical spine injuries, you can miss other fractures in other places. You have to pay attention, and there are some who end up having neurodeterioration. You should pay attention to multi-system trauma. You have to pay attention to head injury. Pay attention to patients who are on alcohol, and you have to take an adequate and complete X-ray and visualize the top of T1 at the level of the cervical spine. Because we know that the shoulders are in there. You don't get a good C1 or C1, C7 T1 injury. I'm sorry, it's C7 T1. And many times you have to take swimmer's views, take several views to make sure that there's no injury on plain X-rays. The atlas fracture easily missed. Obtain a CT scan because it would tell us more. Only 50% are isolated fractures. Open mouth views should be done. What happens is that atlas spreads and you will have an overhang of the facets. If you have a ligamentous injury, we mentioned that the length of the transverse ligament is 6.9. If this overhang is present, it means that the ligament is torn. If you have avulsion of a fragment of bone with it, you can put them in a hard cervical collar and they would unite. The usual treatment of these cases is by putting them in a halo. Odontoid fractures, we know that you have a tip, the waist, and the body. The tip, most of the time, the ligaments are intact and is stable. The waist, if it's displaced more than 5 millimeters, does not heal. It's a watershed area, and we have problems with it uniting. Another problem is the elderly won't tolerate any form of brace treatment. So surgery is indicated in this case, and you can go anteriorly and put 1 or 2 screws. And posteriorly, you can use the modular technique and fix C1 to C2. So these are the treatments that we do in this case. Bilateral fracture of the part C2 is known as hangman's fracture. It's a hyperextension followed by a flexion injury. Usually, the majority of these cases have a neurologic intact. They usually heal despite displacement, and you should reduce interaction and then apply a halo. You have to know the classification of Hangman's fractures into special types 1, 2, and 3, 3A, 3B, where you have a dislocation of the facet joints, and these require open reduction. Now, let's speak about facet dislocations in the lower cervical spine. Unilateral occurs in 25%, bilateral 50% facet dislocations. Spinal cord injury worsens with increasing displacement. Skeletal traction plus closed reduction is the treatment that I personally use. Usually, they end up with a posterior spinal fusion for reduction. Irreducible, you need to an open reduction, and posterior spinal fusion should be considered. What about the vertebral body fractures? These fractures have a high association of spinal cord injuries. You have the teardrop fracture, disruption of the posterior cortex, and posterior ligamentous injuries. A stable fracture will heal in a brace or a halo, usually stabilize if spinal cord injury with early rehabilitation. Beware of posterior ligamentous injury. These are highly unstable patterns. Anterior spinal fusion, strut plate, or anterior spinal fusion with strut and posterior spinal fusion combined. Ankylosing spondylitis is a high risk cervical spine injury, and these patients I don't like personally because لما بيقولوا بالعربي بيغدروا. Yes, بيغدروا. I had many patients that had minor injuries ending up with serious fractures. Some patients ended up with epidural hematomas that we had to operate in the middle of the night. And these patients, you should spend more time of bone. These are two patients, one with the dish and the other one with ankylosing spondylitis. The dish, the osteophytes are horizontal and they never fuse. The ankylosing spondylitis is the osteophytes are vertical and they mostly end up in fusion. Pseudosubluxation, it occurs in children at the level of C2-3. Usually it's under the age of 4. The diagnosis is a minimal history of trauma. There's no compensatory lordosis below, and reverses are in extension. Halo use are quite common. You have to use the halo screws, which are put underneath under the influence of a continuous known force with a screwdriver. In adults, you need 4 screws. In children, you need probably 8. As I mentioned at the beginning of this lecture, the cortex or from inside is much thinner than that from outside. And for this reason, you need multiple screws. We're using more and more the Garden Wells tongs. It's the halo, the ideal orthosis of the upper cervical spine, where in doubt, you should always use a halo. It fixes the skull relative to torso. It allows in the subaxial region. It's unreliable for immobilizing lower cervical spine, as said John. What are the complications? If you put the pins in the temporalis fossa, this can become loose. It should be posterior margin of the temporalis fossa, and in posterior to the supraorbital nerve. You use total 4 pins for adults and 8 in children, and you need a torque screwdriver to determine how much. The complications include pin loosening, discomfort, and dural puncture. In the pediatric age group, you need multiple pins, 6 to 8. You should thoracolumbar trauma, rule out multi-system trauma, head injury. Beware of the thoracic aorta. You can have a dissecting aneurysm. Beware of abdominal injuries, especially in chance fractures in children. T2 to T12 are usually stable, but are high risk for neural injury. I told you that the core isolate equina lesions. You have to, I still believe in the 3 columns theory, but you have to know that there is the AO, which classifies it into compression and distraction injuries and shear injuries, 3 types. But I usually stick to the Dennis classification, where you have the anterior longitudinal ligament and anterior half of the vertebral body, the middle posterior longitudinal ligament and posterior half of the body, posterior elements. You have the posterior ligaments. You have 2 out of 3 columns. When disrupted, tells you you have an unstable spine. Translational injuries, AP or lateral, these are, we all know, they are unstable. These are shear injuries. You can have a complete spinal cord injury, stabilized for nursing care. You have incomplete spinal cord injuries, which are unstable, stabilized to protect recovery. If you need to decompress, you should decompress. But if you get the patient at the thoracolumbar junction who has a complete injury, and we don't know whether the bulbar cavernous is intact or not, what should you do? Should you operate them after 72 hours, or should you operate them before? Studies have proven that the earlier you operate, the better result you have certain level of recovery. So this, I will tell you this. These are translation injuries. I told you, be aware in multiple crush fractures of the vertebral body, be aware of posterior ligament injuries. You should operate on patients where you have canal compromised by more than 50%, or you have a kyphosis, which is more than 20 degrees. So be careful about this. First fractures, surgical indications, decompression anterior. We go anterior. Posterolateral, anterior for late. Indirect 50% clearance. Then we started doing 2 pedicle above, 2 within the posterior pedicles of the fracture body, and 2 below. But still, in severely comminuted and unstable fractures, it's better to go 2 below and 2 above. Beware of dural tears in these injuries, which is quite common in the comminuted fractures. Chance tractive flexion injury, you have a high incidence of abdominal visceral injuries in children. You have 2 types. You have one passing through bone, you can treat them in a cast, and one passing through the ligaments, you have to operate. Lumbar burst fractures, 4% of all spine fractures. Lordosis affects the mechanics. That's why it's even rare. Treatment usually is non-operative. And the only time we do surgery is for progressive neurologic or deformity and severe neurologic and deformity. Lumbar disc disease. This is nearly towards the end of this lecture. I hope that you will stay because this is my best portion of the lecture. These patients have low back pain. 50 to 80% of people have a lifetime history of back pain. In the United States, $100 billion of worth go to low back pain problems and discs. The 90% resolve in first months. 90%. There are certain regions where 90% they do surgery. This is wrong. What are the risk factors? Obesity, smoking, gender lifting, vibration, sitting, job dysfunction. The red flags. You have to be aware of a patient who has low back pain. Be very careful from him having a tumor. infection, beware of trauma, pursue the red flags, failed non-operative treatment. We don't like to take x-rays or MRIs in the first months. There are some centers in 6 weeks. L4-5 is the most common. The result that causes it is recurrent torsional strains, lumbar spondylosis. They have disc desiccation due to load is on the posterior facets, and they end up having degeneration. Also, they will have disc bulging, osteophytosis. They have abnormal kinematics with further degeneration. We come to this point repeatedly. So far, twice I discussed this. Now this is the third time. From age 20 to 39, 21% have a herniated bulge and degeneration. Age 40 to 59, 22% have herniated nucleoposis, and 50 to 59% have degeneration. And from age 60 to 79, 36% have a herniated nucleoposis, 21% have stenosis, and 79 over 93% have a bulge and degeneration. You have to be able to tell what level it is. If you have a posterolateral lower okay, we spoke about this. The foraminal, they are far lateral, they are less common, 10%, and the upper numbered root from L4 to L5 is L4. The diagnosis, history and physical examination, the X-ray of limited utility, wait for weeks before, and completely non-specific. An EMG and nerve conduction velocity are useless. Neuroradiography, MRI is sensitive and specific, but clinical correlation is essential, obtained as a pre-op test. The tension signs. Most important are the most predictive physical findings, straight leg raising sign. We spoke about it. I will not go through it. And the femoral stretch sign. The natural history, 90%, I repeat, 90% or more improve without surgery. Most are better by 4 to 6 weeks, some 12 weeks. In operation vs non-operative results, we studied them and we found that they are the same at 4 years. Non-operative treatment is progressive paralysis and has a Coda equina syndrome. These are indications for surgery. So, non-operative treatment, rest, moist heat, exercise, injections, and if they don't improve, surgery. So, indications for surgery, I mentioned caudate equinus syndrome, progressive weakness, it's persisting, disabling. The surgical candidate, they have sciatica, abnormal neurofindings, they have a positive tension sign, and confirmatory MRI. So you should evaluate the clinical findings together with the radiologic. In surgery, 90% have relief of leg pain. 15 to 30%, they have persistent back pain. Neuro recovery, 50% motor or sensory. And reflex, 25% might have recovery. Complications are dural tear, recurrent herniated nuclear pulposus, discitis, and vascular catastrophe. In children, injuries of the spine are uncommon in children, but have some unique features, particularly in young children. During the first decade, upper cervical injuries predominate with fracture of the odontoid, being the most common. In adolescents, the it occurs because a young child's ligaments are more elastic when compared with the spinal cord. MRI often provides useful information concerning the extent of the injury. Children with Chihuahua with an unstable ligamentous disruption require spinal and neurologic injuries. So I'm going to mention very few. Why did it stop and why did it begin? Anyway. Okay, I'm going to carry on. Cervical and thoracic lumbar sprains. You have to realize that there are multiple muscles around the spine, and you can get a sprain in them. And this occurs in whiplash injuries following extension, combined extension and flexion injuries. They will have pain in the neck with torticollis and all the problems. You have to pay attention to this. Another point, these are whiplash injuries. It's more common in females, most commonly occurring in motor vehicle accidents, being hit from behind. This is it. And you have to know about congenital muscular torticollis, where you have a scar tissue in the sternocleidomastoid. The patient tilts to the same side and rotates the neck to the opposite. You have to pay attention of how to manage it with physiotherapy and with surgical releases. Okay, so this is the appearance of a congenital torticollis. The head is tilted to the left on the side of the lesion, and the chin turns to the opposite by the sternocleidomastoid. You have to pay attention with torticollis. You have to pay attention to rule out hip dysplasia, because in 10% of the lesions, they have hip dysplasia. Now, you have to differentiate it from Klippel-Feil syndrome. And Klippel-Feil syndrome is a condition where they have short necks, low hairline, fusion of the vertebra. They have hearing loss. They have synkinesis patients. They have cardiac anomalies. They can have scoliosis, Springel's deformity. One scapula is elevated. You have to pay attention to this. This is a patient with Klippel-Feil syndrome. They have low hairline. They have webbing of the neck, short necks. If they have only 1 or 2 fusions, it is not very apparent. But be careful of having an associated kidney problem or cardiovascular problem. Pay attention to this. Okay. Another point is atlantoaxial rotatory subluxation, where you have in 4 types. Sorry, I need to drink. I have very little to give yet. طولوا بالكم علي. In type 1, you have no subluxation. It's fixed rotation of C1 on C2. It's fixed. It does not, you have a rotation type of displacement, and the vertebral displacement is less than 3 millimeters anterior dislocation. You see there is slight anterior dislocation. In type 2, you have a unilateral anterior atlantoaxial subluxation, and you see, if you look at the atlas, the anterior arch, it's displaced more anteriorly. On the left-hand side, type 1, it is less. And in type 3, you have bilateral anterior and anterolateral subluxation of C1 on C2. And in type 4, it's a posterior dislocation of the atlas on the axis. This occurs commonly following infections in children of the pharynx. And it used to be common during the periods of tuberculosis. And the treatment, of course, is conservatively put them in traction, put them for some time in collars, and they would recover. The far majority would recover. So most neck rotation, 50 to 60%, occurs at C1, C2 level. Atlantoaxial rotatory subluxation may occur in adults, but it's more common in children between 2 and 12 years, probably because of the greater ligamentous laxity in children. Atlantoaxial rotatory subluxation most often occurs after minor trauma or upper respiratory tract pharyngeal infections. And this shows you of how it's rotating and moving forward from C1, type 1, 2, and 3. In 1, it moves minimally sublux. The atlas moves on the axis. Type 2, it is more sublux. Type 3, both sides, from not only from one side. It's not only rotatory. Both sides are dislocated forward. And type 4, it's a posterior displacement. Children with atlantoaxial rotatory subluxation hold their head in a cock-robin position or torticollis position. The positions of the head and chin are similar to positions in congenital muscular torticollis, but the sternocleidomastoid spasm in atlantoaxial rotatory subluxation is on the opposite or shin side. Anterior, posterior, and lateral cervical spine radiographs findings are normal. The odontoid view shows asymmetry of the space between the odontoid and C1 lateral masses. However, this radiographic view is difficult to obtain in atlantoaxial rotatory subluxation. Dynamic CT views with the head maximally rotated to the right, then to the left, may be required for confirmation of atlantoaxial rotation, sublux. Symptoms in most patients spontaneously reduce within a week with bed rest and mild analgesics. Longer duration of symptoms requires traction followed by the use of hard collar. Rarely persistent subluxation requires operative treatment. Spinal deformities, I will briefly say you have failure of formation, you have failure of segmentation, and if you have failure of formation and failure of segmentation on the opposite side, you'll have a severe form of scoliosis. If you have failure of formation of the anterior vertebral body, you'll end up having kyphosis. You have to be aware of these. These patients, we don't like to operate early because they will go into cor pulmonale and die at an early age. So on the right hand, you have hemivertebra, failure of formation, and on the left side, you have failure of segmentation. So you have to be careful because many of these are missed at birth. You have to put them in braces if it's progressive. You have to use growing rods so as to maintain them in correction until a time where you can do surgery and be at ease that the alveoli will still develop. Scoliosis, I'll tell you, scoliosis, you have I'll go to this. If you look at a patient, you see that it's a lateral deviation of the spine to one side. There's an element of rotation and sagittal depression. So you have, in the past, we used to think you have kyphosis with scoliosis. Nowadays, we know it's lordosis. Due to this curvature, you have a rib hump. And the way we measure it is by doing the Cobb angle. We know that it consists of rotation, and the amount of rotation, which is maximum, is at the apex of the curve. The end vertebra are the vertebrae which are most tilted in the concavity of the curve. The way we examine these patients is while the patient, we are sitting on a chair and we look from behind, we can see the rib hump. There is a scoliometer that helps in diagnosing scoliosis, but many schools use it. You have to pay attention that these patients have differences in heights of the shoulders, difference in the heights of the pelvic iliac crest. You have to be aware of lower extremity shortening in these cases. So we have these types. We have the idiopathic, which is unknown, the cause. Infantile occurs before 3 years, but the difference is the convexity in these cases are on the left side, while in the juvenile and adolescents, it's on the right side. We know that these children will many of them might disappear completely. By using special measurements, we're able to say which is progressive, which one is not. And that's it. The ones who they might have a dysymmetry in the face and the body, etc. The juvenile is idiopathic from 3 to 10 years. It resembles the adolescence. And after 10 years, we have the adolescence. We have congenital scoliosis, as I mentioned, failure of segmentation and formation, neuromuscular scoliosis, where you have long curves, cerebral palsy, myelomeningocele, muscular dystrophy, where we have to operate quite early, cerebral palsy, many times we have to operate wide because of this symmetry of having the buttocks on the chair. They can end up having sores from in the buttocks if they cannot bear weight or cannot have weight on both buttocks equally. so we're forced to operate. Muscular dystrophy, we operate them early because we want to give them a maximum chance to survive. Spinal muscular atrophy and Friedreich's attacks. Vertebral conditions, we all know that benign bone tumors, an example would be a osteoid osteoma. You have also bone infections and metabolic bone diseases. All these can cause scoliosis. Spinal cord conditions like syringomyelia, tethered cord syndrome, neurofibromatosis. We know that neurofibromatosis is associated with a very rigid curve. It has two curves, short curves and a long curve, but they're rigid, and it's associated with cafe au lait spots and neurofibromas. Connective tissue disorders are like Marfan syndrome and Ehlers-Danlos syndrome. So you have to pay attention. The parents pay, and there are many that the parents don't pay attention. And with time, there are others who they discover them when they're making the clothes, being that they cannot make the legs equal, etc. Okay, so forward bending tests will let the rib hub become more apparent. You have to know about the rotation, the Mohs classification of rotation, how you evaluate it. You have to know these. Okay. Left-sided thoracic curvatures have a significant association with syringomyelia. We know that the curve is mostly on the right side, meaning that the convexity is on the right side. You have to pay attention to this. You have to know how to do the Cobb measurement. These are important. You have to know how to tell the difference between a primary and a secondary curve. These are points. That's what we want you to know. We don't want you to know how to treat this condition. It's too early and too specialized. You have to take long x-rays. We call them chiropractor views. And nowadays we're using the EOS, the electrical optical system, where there's less radiation, and we can take very nice views, long AP, long PA, and lateral. We're taking PA and not AP because we're afraid from breast cancer later on in life. So another point is a question they will ask is when to operate. If you have an adolescent idiopathic scoliosis at the much beginning completion of the growth, and the way we complete the growth is the apophysis, the rhizosis, the apophysis of how much the apophysis has closed over the iliac crest. If it's towards the end and you have a curve more than, let's say 40 degrees, this is an indication for surgery. So these are points. Complications include infection, neurologic injury, and pseudoarthrosis. Kyphosis, I want you to know about what do you call it? Scheuermann's disease and postural. The Scheuermann's, you need 3 vertebrae, which are 5 degrees. It can occur in the thoracic wedging of the vertebra, 5 degrees, 3 vertebrae above each other. And it can occur in the thoracic spine and lumbar spine or thoracolumbar spine. And these, at certain angles, they need surgery. You need to straighten them, but you have to know that 50 degrees is the limit. And you can put them in corsets when less. So yeah, more than 5 degrees anterior wedging in at least 3 successive vertebrae. Okay, that's what I want. Spondylolisthesis, you have to know that there's a defect between the lamina and the pedicle. This is called the pars interarticularis. And you get slipping of one vertebra on the other. You have other type of spondylolisthesis, one which is secondary to what you call degenerative arthritis of the spine, and this never exceeds more than 2 stages of slipping. There is a classification for the vertebral bodies. You have to know of how much slip occurs. There's a traumatic spondylolisthesis. There is a pathologic spondylolisthesis, and you get a abnormal form where you have long pedicles, long. This is a dysplastic spondylolisthesis. So the problem is the pars and articularis. I don't want to go more. You can look at my my lecture and study it, because this is too long. And believe me, I don't have a voice left. And thank you very much. في شيء أسئلة؟ في شيء أسئلة يا جماعة؟
Thank you very much, Dr. Jone. It is a very clear lecture and comprehensive about the spine. So thank you very much.
يعني بيناتنا يا خالد أو whoever's talking.
عبد الرقيب.
عبد اللطيف. عبد اللطيف.
عبد الرقيب.
سلام.
عبد الرقيب.
لك يا أهلا.
المرة.
كل شيء بقول لك إنه I covered all the spine. في محلات عجلت شوي عليهم، بس ما بقدر أعطي كل spine in one session. فأعطيتهم إياها، بس لازم يقروها، لازم يطلعوا عليها. هاي الطريقة إنه بيقدر يحفظوها. عرفت كيف عبد؟
Yes.
To be honest, this is